a standard examination, neck posture, all the rest.
Yes.
But then we're specifically targeting instability, glenohumeral instability. And this is applying if you're multi-directional hypermobile, and also if you're specifically got trauma. So actually the first thing we do is we just look at hand. If you can get your finger extending to more than 90 degrees, if you can get your thumb onto your forearm, if your elbow hyperextends, so it'll be 1, 2, 3, 4, 5, 6, and then the knees hyperextension 7, 8, and then you can put your hands flat when you're bending forward. I'm going to show you how far I can. Alright, so you're looking at Baton's criteria for hypermobility. And then coming specifically to the shoulder, just looking and seeing in somebody who's hypermobile, often they'll have a little sulcus between their acromion and their humeral head. So you'll see a little furrow there. And you also determine if there is a sulcus sign, and you can pull the head down. And here I can get a little bit of a movement, which is normal. And it's only a problem if it's asymmetrical.
Okay.
So if I did it to the other shoulder, and this side went glonk, and especially if it went glonk with a click or a grind, we say, okay, there's something issue, something problematic. And then there's the so-called Gabye sign, which is a hyperabduction test. And you, I'm afraid, would actually fit that criteria. So you're getting about, you're getting about 20 degrees of hyperabduction. And again, if it's symmetrical, it's not a problem. If it's asymmetrical, then you've got to worry about that inferior capsule that's now ruptured, and you can get too much.
Okay.
And then the usual test, just looking at how much external, how much internal rotation you have. A rugby player, this 10 degrees of external rotation might be normal for him. So you don't know that just because you've got decreased external rotation that you have a problem.
And that's why you check left and right.
You
Always.
look at symmetrically. Yeah. And you also look at muscle mass. So the more muscle mass you have, the less range of motion you're going to have just naturally. All right, then we get you to lie down. Okay, so anterior shoulder instability. Okay, so that's when the ball wants to come out the front. I typically do 2 little tests. The first one is just what we call an anterior glide. So I'm getting a little bit of axial traction. I'm pulling the arm down like this, and I've got my thumb on the back of the humerus, and I'm just pushing forward a little bit. And you can feel the glenoid, you can feel the humeral head on the glenoid, and you can gauge how far you can push it front and back. Grade 1 instability, it goes there, but it doesn't go up onto the rim. It stops short of going onto the rim. Grade 2 goes up onto the rim, but it comes back. And a grade 3 will go up and over the rim and doesn't come back just by itself. Now, you being a pregnant female, you've got a grade 1 laxity. I can translate your humerus onto the edge of your rim, but as soon as I let go, it just drops back into a socket there. And it's important to notice, is there any click or is there any grind associated with that? That can be a sign that there's a labral tear as the head goes up onto that labrum, grinds it, and then comes back. Okay? So for an anterior, you can do an anterior load and shift. All right? And then we can do the same thing, relax again for me, for a posterior. Relax your arm. That's it. A posterior, again, I'm putting a little bit of longitudinal traction this way, and then just a little posteriorly directed force on the humerus. And you can feel that. You can also do it with your other hand and pushing the head of the humerus back. And here there's no significant translation. Alright, and then for anterior instability, we would also do the ABA test, which is taking the arm out into abduction, elevation, external rotation. Alright? Now somebody who is apprehensive, so their shoulder feels like it's going to come out. If you go into this position, they're already going to be going, ooh, not comfortable. Getting some pain, and then it's feeling the humerus translating onto the anterior rim. So this is a so-called apprehension component. You can provoke it more by now trying to push the humerus out the front. So I've got my hand behind here, and I'm pushing it out the front, even as I go into more external rotation with the arm. So if you go into external rotation and pushing it forward, somebody who's anteriorly unstable is not going to like that. But then, if they're in this position, you're comfy.
Oh, but
If they're in that position, and then you do a posterior or a relocation force, you push the shoulder back in, and immediately their face relaxes. They go, oh, that's so nice. And then a very sensitive test is if you keep that position of the arm, you're pushing the arm back in and you release your pull. And they go, ooh. So there's a release. So there's a apprehension, a relocation, and a release component. And those three are pretty diagnostic for anterior instability. And at posterior instability, you do the so-called FAIR test. So we want a combination of flexion, adduction, internal rotation. Okay? You can do this with the patient sitting as well. You can also do it lying. So first of all, if you just go into a FAIR position and you just do a posterior force, you're pushing the arm back down. You'd really, that if somebody's sore, they might, if somebody's unstable at the back, if they've got a posterior lesion, they might even be sore there. But then you can go and provoke it more by doing a flexion, adduction, internal rotation. So as you come up, you flex, you adduct, and you internally rotate.
So sore, that would be...
Sore, click, or a painful click.
Okay. Nice.
And nothing like that.
That's good.
Not yet.
Yeah.
Very often with an instability like that, because you can't see the structures in the joint, you'll end up having an MRI.